course would approach. So basically, we will have 4 days per week classes. Most probably that would be on Tuesday, Thursdays, and for the convenience of all the doctors, we are also taking classes on weekends, that is Saturday and Sunday. So, what we are planning is we will be progressing our course in terms of taking subject wise. Like for example, if we are starting with say central nervous system, so we might take 2 days to complete the theoretical part. Maybe like the classes would be 1.5 to 2 hours per day. So we will take two days. We might take to complete the theoretical part, and then we will be providing you a subject wise mock analysis on the portal, so you guys can attempt those questions that would be related to the topic which have been taught to you on the theoretical classes. And then we might take 1 or 2 days to actually discuss those questions uh, which is related to the topic. And I think that is the most important part to focus on, because this is a competitive exam and we need to learn the approach to answer those questions. So we will be discussing these questions, and we actually want to focus more on that part, because theoretical knowledge we all have. It's just that we need to understand how to approach the questions. So we will be discussing those subject wise questions, and this is how we'll be completing the course in say 12 to 16 weeks. And then we will have 2 or 3 grand mock tests, which will mostly be on the basis of say recall questions which we receive, or most important topics which are there. And at the end of the course we will also be taking some important miscellaneous topics which we actually don't we think like we will attempt these questions on the last, or we will learn these guidelines at the last, but they are very good scoring questions, say coming from guidelines, screenings, population health, ethic behaviors. So we will be discussing those separately, maybe like in 1 or 2 lectures. And yeah, so this is how the course will progress. It might take 12 weeks or 16 weeks, whatever time it will take. We would like to convey every important part of the exam which is necessary for it to take part. So yes, this is how the curriculum will be. The timing for the classes will mostly be in the evening. We are planning from 8, like Sydney timing, 8 p.m. to 10 p.m. I think that should be around 3:30 or 4 in India. Yeah, I have a question in the chat. Will 16-week cover most of all the topics? Yes. So that will complete all the important topics, uh, like which are required for the exam. But we are taking 4-day classes so that you have enough time to prepare by yourself the topic we are trying to convey to you. Dr. Nishit is asking, lecture we attend is enough for preparation? Um, See, there isn't any definition of enough, because this is medical field. But yes, if whatever thing we are providing you is the most important part, so if you try to cover, remember, and recall those, along with your own preparation, that should be enough. With the mock test and subject wise tests, that should be enough.
So I think certainly I think you can start. Rangan, can I start? She can start.
Yes, we can start with the curriculum and with the detailed discussion.
Okay.
Okay, so I'll be sharing my screen.
Dr. Swapnil, there is still a question on the chat box, if you can answer him.
Yeah,
And
sure.
then
How
How
much
much
time?
time?
Yeah.
How much time it takes to prepare for a fresher was a gap of 10 years. It depends on individual. Like for me, I completed my MBBS in 2015, and then I did post graduation. So I was also off the clinical field for 4 to 5 years. But then for me, it just took me 4 months, like complete dedicated 10 to 12 hour studies of 4 months to crack this exam. It depends on individual, but it is like they say that 6 month preparation is more than enough if you actually know how to approach the exam. But if you don't know, then no, there is no time limit. So it depends on individual how much time you can give to prepare for this, exam. Oh, good. So let's start. Um, so I assume the screen is visible to everyone.
Yes, visible.
Okay.
Visible.
Okay, guys. So for today's lecture, the topic is acute abdomen. So it will be just an overview of the topic because it itself is a very uh, vast topic to cover, but it is also very important topic for the exam. So we will be just covering the overview, and I will also share with how the questions are asked and how we approach these questions. So, yeah, let's start. So, as we all know, what is acute abdomen? So, uh, why acute abdomen is important? Because it is an immediate medical attention, or it is an immediate medical emergency. And that is why this topic is very important for AMC, because we have already declared discussed in the last orientation class that whatever is the emergency or life threatening situation, those are usually asked in the exam. So so for them, acute abdomen is very important in terms of competitive exam, and also in terms of clinical patient care, because it is a condition, if it is misdiagnosed or if it is not treated, managed acutely and immediately, it can lead to severe morbidity and even mortality. So, how do acute abdomen present? So, it is a sudden and severe abdomen pain. It also presents associated with many other symptoms, but most important presentation will be sudden and severe abdomen pain. Now, we all know that abdominal pain could be due to a lot of reason, and even acute abdomen is just a presentation. We need to identify what is the underlying condition behind it. Now, we all know that we categorize abdominal pain on the basis of quadrant it will present with. So these are the different scenarios which I have presented over here. We won't be discussing every bit of this, but what we need to understand in terms of AMC exam is that what is the when a patient present with severe abdominal pain, what could be the probable diagnosis, and what are the diagnoses which we have to keep in our differential, so that we do not miss very important part of it, which can actually lead to severe mortality. So probable diagnosis can be just an acute gastroenteritis. It could be an appendicitis. It could be IBS or IBD. It could even a renal colic can present as abdominal pain, or it could be as serious as perforated viscus. So now, what are the disorders which we have to keep in mind as a differential while solving these questions? Is that even an inferior MI can present as severe abdominal pain. It will have associated symptoms of MI, but it could also present with severe abdominal pain. Then your ruptured abdominal aortic aneurysm can present with abdominal pain. We have mesenteric arterial occlusion or ischemia. We can have bowel obstructions. We can have severe infections like salpingitis or pancreatitis. In a pregnant female, it is just like always a rule to first go for in a reproductive age female. We have to do a pregnancy test to know that whether patient presenting with severe abdominal pain could also have ectopic pregnancy. Other causes which are important in terms of question is also sigmoid volvulus. So we will be discussing some of these in the next coming upcoming slides. So this is what we are focusing on today. What causes of acute abdomen are mostly asked in terms of questions. Now, coming to clinical presentation, acute abdomen can present, as we have discussed, can present with severe abdominal pain, which is usually sudden in onset. Now, this feature is very important for us to differentiate among the causes which we have discussed over here. Now, this abdominal pain can be colicky, can be crampy, can aggravate with movement, can decrease with movement, can also be associated with tenderness, guarding, or rigidity on examination. Now, on the basis of these symptoms, as we have already learned in our MBBS years, we can actually differentiate most of these clinical presentation. Then coming to associated symptoms with abdominal pain, it can present with nausea, vomiting. Nausea, vomiting can be an important symptom, in terms of obstruction. Distension of abdomen along with nausea, vomiting, and abdominal pain is an important, tetrad to diagnose obstruction. Then, uh, altered bowel habits is an important symptom in terms of your diverticulitis, even in terms of your colonic cancer. Then, severe or acute abdomen can also present with signs of systemic inflammation like tachycardia and elevated WBC count. Now, an important part of AMC exam is red flags. You have to remember and understand all the red flags presenting to certain conditions. For example, for acute abdomen, so, what are red flags? Red flags is something, if it is given in the question or if a patient is presenting with these symptoms, then that is an bell to ring that there is something serious going on, or there is something you have to look, assess, diagnose, and manage acutely and appropriately. Okay, so what are the red flags when a patient present with acute abdomen? Is there any history of collapse in the toilet? That means, is there any intra-abdominal bleeding going on? Is there any symptom of lightheadedness which could be due to any bleed inside which is not presenting and patient may be bleeding inside? Is there any history of ischemic heart disease, as a patient with ischemic heart disease or atrial fibrillation can have a thrombus dislodged and can cause superior mesenteric artery occlusion or mesenteric ischemia that can present as acute abdomen? Then, as we have discussed, that progressive vomiting, pain, distension is an important tetrad to go for, bowel obstruction. Then, is there any history or diagnosis of malignancy, or is there any history of lack of, passing of flatulence, which is also pointing toward obstruction? Sorry. Now, what are the signs which are important, which we need to look in a patient presenting with acute abdomen? So, as we have discussed over here, that acute abdomen can present with, perforated peptic ulcer, can be an important cause of ischemia or obstruction. Or it could, simply be any appendicitis or pancreatitis leading to peritonitis. Now, when a patient present with these things, you have to keep in mind that whether the patient is stable or unstable, what are his vitals. Now, if a patient is present with all these symptoms, is presenting with pallor or sweating and has hypertension, this could lead to a, a hypovolemic shock. Whether, as I've already discussed, whether the patient has atrial fibrillation, it could be a cause of mesenteric ischemia. Whether a patient has fever with tachycardia, tachypnea, and these symptoms can point towards sepsis. Pancreatitis can progress towards sepsis. Even in females, pelvic inflammatory disease can progress towards sepsis. So we have to keep these signs and symptoms in mind when we are solving the questions, because these are the pointers which will lead us toward a diagnosis. Now, this is a diagnostic approach. I've taken this from diagnostic imaging pathways. Now, what we have to understand over here is, when we deal with a question presenting with acute abdomen, first we need to locate the position where the patient is presenting with symptoms. It could be upper quadrant, could be iliac fossa, could be a generalized pain. Now, when we know that if it is an upper quadrant pain, it could be biliary, could be pancreatic, but mostly it is biliary in origin. Then, if the patient is having acute right iliac fossa pain, in a non in pregnant females, this could be ectopic. In non-pregnant females or in other patient, this could be acute appendicitis. Now, coming to when a patient present with generalized pain, what we need to first understand is whether the patient is stable or not. This is a very important part when we are dealing in questions with AMC, because generally it could be a same question. For one, it will come as an unstable patient, and for other, it could come a stabilized patient. And just on the basis of this, your answers will change, because if it is an unstable patient, your approach will be first to stabilize the patient and then progress toward your investigation or anything else. But for a stabilized patient, your approach will be totally different. So, coming to to a patient who is presenting with a generalized pain symptom. It could be acute pancreatitis, it could be a perforated viscous, or it could be anything which we don't know, which we have to come to a conclusion after diagnostic imaginings. It could be, abdominal aortic aneurysm which has ruptured. So this is how we go towards, confirming our diagnosis. If it is a perforation, our first line of investigation will be a im- X-ray, plain X-ray. It will be a direct chest X-ray and an abdominal X-ray. So usually how the question will come will be like, they will give you a scenario where there will be all the clinical histories and symptoms pointing toward perforation, and they might ask you what will be your next best approach, or what is your first next investigation, or what will you do first. So if the question is towards an unstable patient, your answer will be to stabilize the patient. But if it is already a stabilized patient, you will first choose to do a plain X-ray to confirm whether it is perforation or not. Now these are the specific, like this is very brief description because we won't be discussing the whole topic today, but to get a hold of the topic, let's just revise few important points regarding these scenarios. So we know how acute appendicitis present. So it is usually a right lower quadrant pain. An important pointer is McBurney's point tenderness, and there is rebound tenderness. Also, we know about appendicitis is there are marching of symptoms. It will present with anorexia, nausea, vomiting, pain, and then there are many signs which we do to actually come to a diagnosis, and then there is mentrals which we do in terms of investigation. On imagining, we can do ultrasound or CT scan, which will show us an inflamed appendix. So what is acute cholecystitis? So it will present basically with an upper quadrant pain, and we know that it is positive for Murphy's sign. So what is Murphy's signs? It is a pain on deep inspiration when you palpate the patient. So what will be the imagining done? So imagining will be ultrasound, and it will show a thickening around the gallbladder, or might also show you the gallstones in that. Coming to acute diverticulitis is a left lower quadrant pain. So even these pointers, which show you the position of pain, can help you diagnose a lot. A patient with appendicitis and cholecystitis will have right upper or lower quadrant pain, whereas diverticulitis will have a left lower quadrant pain. One important point regarding the diverticulitis is the pointer is the patient may present with change in bowel habits, which will not be there in case of cholecystitis or appendicitis. Coming to imagining, we actually need CT scan to diagnose diverticulitis, which will show you inflamed diverticular or may show complication like abscess formation. Now coming to intestinal obstruction. Now we know intestinal obstruction can be mechanical or functional. So we'll be discussing mechanical over here. Functional we will be covering when we are discussing the whole topic in our course. So how do an obstruction present? So obstruction will present with abdominal pain, which will be colicky. Then there will be symptoms of abdominal vomiting. In like vomiting will be first presentation and then distension in terms of small bowel obstruction. And if we are dealing with large bowel obstruction, the symptoms will be pain and distension, and then progressing towards vomiting. So this is the main differentiation which we see in terms of small bowel and large bowel obstruction. Also, we have imagining to help us with the difference between small bowel and large bowel, and we'll be actually seeing a case on the basis of these pointers in the upcoming slides. So when we do an X-ray for obstruction, we see dilated loops of bowel. So for small bowel obstruction, we know the rule of 369, that great bowel diameter greater than 3 centimeter, cecal diameter greater than 6 centimeter, or colonic diameter greater than 9 centimeter leads us to a diagnosis of obstruction. And there are many more differentiating features on X-ray also between small bowel and large bowel obstruction. Coming to perforated viscous, perforated peptic ulcer, how will this present? It will present with sudden onset of severe epigastric pain. An important pointer for this will be a rebound tenderness. as it is a perforated viscous, and there will be peritoneal irritation and inflammation, which will give us guarding rigidity or rebound tenderness. The stages for perforated peptic ulcer usually go through this three reaction. There is prostration reaction and then may progress to peritonitis. The patient is usually in sudden severe pain, will be anxious, sweaty, and there will be deceptive movements. On imagining, we will see free air under the diaphragm. The last one is acute pancreatitis. Acute pancreatitis, most specific finding which they give or is a pointer in the examination, is a epigastric pain which radiates to the back. If investigations are given, they may point towards elevated amylase and lipase. Lipase is more specific for pancreatitis. When we do imagining, we can do ultrasound or CT scan, and which will show us the inflamed pancreas. You might find complication of pancreatitis on imagining, which could be pancreatic pseudocyst or pancreatic abscess. Now, how do we manage manage the cases of acute abdomen? For every patient presenting with acute abdomen, we need to remember, when we are asked like what will be your first step in management or what is the next best approach or step, you have to first see in the scenario whether the patient is stable or not. If the patient is not stable, our first most important thing to do is to recognize and stabilize the patient. Next thing is, we will start with intravenous fluid resuscitation. We will keep the patient nail by mouth, and we are doing this because most odds cases of acute abdomen might need some kind of surgery, or actually the process is in the intestine, and we don't want to aggravate the process by increasing the movement. So we keep the patient nail by mouth and actually start intravenous fluid resuscitation to these patients. Next come in line is, you have to comfort the patient by providing analgesias for the pain. In some cases, antibiotics is given. And then the last is surgical consultation. So what happens when a scenario is given, they will give you all these in the option, and our first instinct is to directly go for the definitive treatment. Okay, so they are not asking us definitive treatment most of the time. They are asking us, what will you do first? So first will be to stabilize the patient, to start giving IV fluids to relieve the patient from pain, or in some cases we might need to start the antibiotics. Now we'll discuss one scenario on the basis of what we have learned up till now. So here is a scenario of a 66-year-old man who is seen in the emergency department and is presenting with acute upper abdominal pain. The pain comes on suddenly 2 hours earlier, is constant, severe, and present in the epigastrium. Now, the pain is in the epigastrium. He feels cold and clammy and is sweating. Movement makes the pain worse, and he can only take shallow breaths. He has upper abdominal tenderness and rebound tenderness. The patient is normally in good health and has never had this pain before. He has a history of smoking 20 cigarettes a day. A recent routine check showed his cholesterol was marginally elevated. Which one of the following would be the most likely explanation of his symptoms? Now, this is the typical kind of questions which come, and you can see that they are lengthy questions, around 6 to 7 lines of details. But what we have to train our mind is to pick up the pointers which they which the question presents to us. So here what I can see is an aged man, is 66-year-old, and is presenting with sudden severe acute abdominal pain. Now, important pointers over here is he feels cool, calm, and is sweating. That means some kind of compensation in the body is going on in terms of, the compensatory stages of shock. Something is going on which is making him feel cool, calmy, and he's also sweating. Another pointer is movement make the pain worse. So as we have discussed that there are certain conditions on which patient restricts the movement because peritoneum has already inflamed, and movement makes the pain worse because of the peritoneal movements. So this is an important pointer. Another important thing given is there is abdominal tenderness and rebound tenderness. We also have history of smoking 20 cigarettes a day, which could give us an important clue to the diagnosis. Now coming to the options given to us, so we have a perforated peptic ulcer, an inferior myocardial infarction, biliary colic, acute pancreatitis, or a ruptured abdominal aortic aneurysm. So how do we approach this question? So now we know that we have a case of acute abdominal pain. um, we have some red flags going on with us, with tenderness, with cool calmy skin, sudden pain in the epigastrium. So how do we rule out these questions? So let's start with last one, the ruptured abdominal aortic aneurysm. So ruptured abdominal aortic aneurysm, the pain will can be in epigastrium, but is mostly in the lower abdomen. Usually there is a pulsatile mass, and in the history they will give you something related to, you know an hypertensive patient, something like that. Also, an abdominal aortic aneurysm will not be presenting with movement that make it worse, or there will not be specific finding of abdominal tenderness. Acute pancreatitis is definitely a differential diagnosis over here, because it can present with abdominal tenderness, and but with acute pancreatitis the pain is usually generalized and is, you know gradual, and then it becomes severe. And very important differential is, pain does not movement does not make the pain worse in acute pancreatitis. Also, it radiates to the back, which is not given over here. Coming to biliary colic, biliary colic pain is colicky in nature. That means it will not be constant. It will be coming and going, and patient will not present with such severe symptoms. Coming to inferior myocardial infarction, patient can have all these symptoms, but there will be some presentation relating to chest pain, or they will give you some history which will point towards an MI. So we are left with perforated peptic ulcer, which actually fits all this scenario, that a patient has a history of smoking cigarettes, is presenting with a pain in the epigastrium, which is sudden and severe. Because of the perforated viscous, he's also, there is peritoneal inflammation, there is abdominal tenderness, movement is making the pain worse, and the patient is also feeling cool, calm, and is sweating. So as you can see that when they give a scenario, and when you go uh, to look at the options, it feels like every of the scenario can fit into it. But if you don't need know the pointers to catch, to you every other option will seem to be most likely explanation. But that is not how the exam works. You have to recall and remember certain points which are very important to a specific diagnosis, so that we can solve the question. So now over here, uh, we know that for a perforated viscous, movement makes the pain worse. It is a sudden and severe onset pain, and there is a presentation of abdominal tenderness and rebound tenderness. So on basis of these, we can select perforated peptic ulcer as our most likely explanation. So this is the same thing which I have discussed, that the patient with perforated viscous will present with acute sudden severe symptoms of pain. Movement will make it worse. There will be features of shock and peritonitis. Now, how do you investigate for such patients? So the next question can be, what will be your first investigation, or what will be your first response to such patient? So we do a urgent erect chest X-ray. This will give us a free air under the diaphragm, which will lead to us to a diagnosis. Also, we can do amylase and lipase, which is done to exclude acute pancreatitis. Then to confirm, we can do CT scan, which is the best investigation. But to start with, what is the first line? So first will be your erect X-ray. Management we have discussed. We have to first stabilize the patient, give fluids, keep the patient NPO, provide analgesia, and then surgical treatment is the definitive treatment. Now coming to another question, which is of a 85-year-old man who attends the emergency department, and now he has a 2-day history of cramping abdominal pain. also distension and vomiting. He has absolute constipation. The patient is normally bedbound in a nursing home, has a medical past history of laparotomy for appendicitis, is on medication for Parkinson's disease. The plain abdominal radiograph is shown. Which one of the following is the most likely underlying cause of the problem? Now, here you can see that we have an 85-year-old man who is complaining of cramping abdominal pain, distension, vomiting, and constipation, absolute constipation. So, here something is pointing us towards obstruction. Okay, so there is a bowel obstruction going on. To support our diagnosis, they have given us some clues like the patient is bedbound in a nursing home. Then they have given us a history of previous surgery. So usually if a patient has previous surgical operation done, intestinal adhesions can lead to small bowel obstruction and is also the most common cause of small bowel obstruction. They've also given us a clue that the patient is on Parkinson's disease, so he's on medication, and we know anticholinergic medications reduces the motility of the intestine. So this add on to causing absolute constipation. We are also given an abdominal X-ray, which, as you can appreciate, is showing us this large loop, and we can see that there is dilation of the bowel, increase in the diameter of the bowel. So they're asking us what is the underlying cause of the problem. Now, from the scenario we know that this is a case of bowel obstruction. So what they have given us as the options are whether it is carcinoma, whether it is a sigmoid volvulus, whether it is fecal impaction, whether it is drug-induced pseudo-obstruction, or it is an adhesion obstruction. Now, as you can see, all of these can cause obstruction. So for us, the choice is not to select whether this is appendicitis, pancreatitis, obstruction, diverticulitis. No, they don't present you with questions like that. They are giving you all the causes of obstruction, and now you have to pick the most likely underlying cause for this problem. So how do we approach these questions? For this, we have to have a knowledge that when a patient, what will be the likely cause when a patient is a bedbound in nursing home, has a additional history, and also and is on a medication for Parkinson's disease. So it could be like the presentation could be any of these, but in an 85-year-old man with presenting with obstruction, is bedbound in a nursing home, is an important history, and with an abdominal X-ray, which is giving us an impression of a dilated loop, points more towards sigmoid volvulus. It could be carcinoma of sigmoid colon, but with carcinoma, the patient will have some previous history of alternate bowel movements, can present with bleeding rectum. Fecal impaction can be there. There could be drug-induced pseudo-obstruction and even adhesion obstruction. But when the question presents to you with a history of bedbound and supporting history like this, the most likely explanation is sigmoid volvulus. So for sigmoid volvulus, another important thing which we have to remember is the X-ray finding. And we often say that it is a coffee bean appearance. And it is usually associated with neurological conditions like Parkinson's. The presentation will be same as we have discussed for obstruction. Could be a pain, distension, absolute constipation. Vomiting can occur, but usually will be a late sign because it is a large bowel obstruction. If the presentation is of small bowel obstruction, vomiting comes before distension. So this is what I was talking about. When you investigate the patient with X-ray abdomen, what we see is a coffee bean appearance. So this is the coffee bean appearance, which is most frequently asked in the exam. So why this is called coffee bean appearance? Because this is the sigmoid colon and it has been twisted on his mesenteric base. So this is the mesentery, and on the base of it, the sigmoid colon has twisted around, causing obstruction below and giving us this appearance of coffee bean. So they can just present you with this scenario and maybe like ask you what will be your next line of investigation. So in that case, we will first progress with an X-ray to find out whether it is obstruction or not. What will be our management? So the first line of management, or initially we have to first decompress the sigmoid colon by passing a sigmoidoscope. So we insert a flatus tube. Usually this causes decompression and release of flatulence and the passage of content. In some cases we have to do surgery, but mostly the compression by passing a tube relieves the patient. So that was all about acute abdomen from my side. I try to give you just an overview of the topic. It is a very large topic which we will be discussing individual scenarios in detail. But from what we have discussed today, the important pointers will be acute abdomen is an emergency situation, and we have to actually provide urgent and immediate medical attention. Common causes include appendicitis, cholecystitis, diverticulitis, obstruction, and perforated viscus. Usually, the presentation will be in the form of severe pain, tenderness, guarding, and sign of systemic inflammation. From the point of examination, we need to understand that prompt recognition and stabilization and early surgical consultation are important. So, for every question, we have to first see whether the patient is stable or unstable and then progress towards the next step. And also, understanding the common cause and clinical presentation, as I said, that like you have to understand and remember that where will be the presentation of acute cholecystitis will be in terms of abdominal pain, where will it be for acute pancreatitis, will what conditions will aggravate with movement of the pain, movement of the patient, what conditions are associated with abdominal tenderness, rigidity, and guarding. So all this, when we understand all these scenarios, we are in a situation to actually come to a point of a differential diagnosis, and then we can with the help of pointers given in the exam, we can come to a conclusion that what could be the most likely diagnosis of that situation. So yes, again, the important point is first recognize and stabilize the patient and then manage the patient. So this was all from my side. If you guys have any question relating to the topic or relating to the course, you can ask.
I guess we have Rohit who has raised his hands.
Yes, Rohit, please.
Hello, ma'am. I had
Yes,
a
Rohit.
question regarding the questions in the exam. Like, are all the questions of the same size, like 7 to 8 lines, or there are multiple choice questions?
See, actually, it changes. Like, when sometimes the questions, every question could be just 4, 5, 6 lines, or sometimes depending on the it actually depends. It is a, sometimes it is luck also, but mostly you will have 3 to 4 line questions, completely 3 to 4 line questions. Very few questions will be there which will be direct questions, but whatever I have seen so far, from the best of my knowledge, I have never seen AMC asking direct questions like what is the common cause, or like just one liner questions. Very rare, could be in coming from population health, but very rare. They will definitely give you a long scenario, and then you need to figure out this scenario.
Okay, ma'am. Thank you.
Oh, good.
There is a question on the chat box from Dr. Yashdeep regarding notes.
So if you're asking about notes in terms of lectures, so no, you don't need to take any notes. So whatever we will be discussing will be with you on your portal, and also we will be providing you some handout materials. So those are very concise form of notes, like that they have been prepared for you, so that when you are just 10 or 15 days away from your exam, you have a concise form of everything just in 4 or 5 lines. Like, say if I say peptic ulcer, so you will have something like what is the pointer for peptic ulcer, what is the first line of investigation, for what will be your first line of treatment, what will you do next, what is the most appropriate presentation, everything in one place for you guys in the form of handout material, so that you can revise that 10 to 15 days before your exams. We will also, like, whatever references we will be using in the lectures, there will be linked to it, so you can definitely go again and again to the links and go through them. But it actually depends on the individual as well. If you are a person who is more comfortable in remembering things on your own way or own form, then you can definitely take notes from whatever we are discussing or guidelines we are sharing. But otherwise, apart from that, we will be providing you links and references and material on the portal. Anyone has any question regarding the lecture we discussed or the course we are about to start? uh,
Hello, ma'am. Excuse me.
yes, Yashdeep. And
Ma'am,
please, you guys can call me Swapnil. I am not like, I'm fine with Swapnil, because we all are at same place.
yeah,
So
डॉक्टर स्वप्निल, आई जस्ट वांटेड टू आस्क कि जो लेक्चर्स हम लोग पढ़ाए जाएंगे अभी, जो आज कवर किया या फिर जो नेक्स्ट लेक्चर्स में कवर होगा, तो अकॉर्डिंगली उन लेक्चर्स का स्टडी मटेरियल हमें प्रोवाइड करवाया जाएगा रिवाइज करने के लिए, कि लाइक एक बार गो थ्रू हो जाए तभी रिटेन कर पाएंगे ना, अदरवाइज
yes,
लाइक
yes,
लाइक वीडियो
yes,
लेक्चर्स में कुछ पॉइंट्स ऐसे होते हैं कि स्पीड की वजह से फॉलो नहीं कर पाते हैं, तो इसीलिए।
yes, correct. So yeah, that is what I actually conveyed right now, that we will be providing you an handout material, which will be a
ओके,
concise form, so that you can go through it. Because when you are approaching an exam and when you have covered so much of every system, it is not possible for you to remember everything. So you need something which is in a very concise form, so that just before exam you have something where you can just quickly recall everything. So those handout materials will be given. And also, when we are providing you the lectures, eh, in the lectures also, there, because see, AMC is not something which you can, it is not a exam which can be just covered in 2 or 3 lectures. So because new questions keep on coming, recalls will be different, so we will be providing you guidelines, references, you can go through those references again and again. So we will be providing you everything from where you can gather the information. So you don't need to worry about the material, we will be providing you.
थैंक यू सो मच।
All good.
I guess Dr. Rohit is still having some questions.
No, sorry. I actually I had one question, Dr. Swapnil.
Yeah, shoot.
Uh,
Yeah.
it is it is not about the course, but are the Australian specialist degree or the license we get, is it valid in India or not?
um I am not sure. Can you please clarify what by license? What are you actually referring to? Are you
It's
referring to
like
fellow?
yes, yes.
Yeah.
I was referring to the specialist pathway. Like after doing AMC 1 and 2, suppose I'll be getting a registration. Then
Mhm.
I'll start with my specialist training. So is
Mhm.
that specialist training valid in India? The specialization in Australia, is it valid in India?
Yeah. So the thing is, if you're asking me whether after completing your the process over here, will you be able to work in India? If you have
Yes.
registration in India, um, like if you have an MBBS registration, you can work in India. To get an MD, like whatever specialization you will be doing, if you are doing it over here, completing your fellowships or anything, I think you have to re-register yourself in India again with the board where you want to practice. And if they can grant you registration, then definitely you can practice. To practice in India, you need registration. So if after completing your studies, you can gain registration in your state, then you can practice in India. And people do come here like for short fellowship trainings. And everyone doesn't want to settle in Australia. So what they do is they come through specialist pathway. They do 2 years of short term training. They gain their fellowships. They gain the knowledge and skills, and they go back and use that skills and knowledge which they have gained over here. And because they have registration in India to practice, so it is a kind of fellowship which you are doing over here. So I
Okay.
think in
Thank you.
India it shouldn't be a problem if you can secure a registration over there. It wouldn't be. It will be an added advantage for you to gain the skills here and then practice over there.
Uh, okay. I was actually an MBBS graduate. Last
Mhm.
year I graduated. So I was thinking of giving AMC one this year. So that's why I was asking
Yeah. So I think this is
should I do an
the,
MD here as I'll be getting a seat through NEET? I'll be getting a seat. So should I do MD here or should I directly go for AMC one?
yeah. So actually the thing is, the choice depends on whether you're planning to settle in Australia or not. So if you're planning to, if your goal is to settle over here, then I think giving NEET will not help that out, because AMC and NEET are two different, very different
Yes, yes.
exams.
I
So it is not like that if you prepare for one exam, you will be able to, give both the exam and expect that both the exam can give you results. No. Though medical knowledge is the same, but the approach to exam and how to prepare for the exam is totally different. And I can say that because I have given both the exams. So that is why I'm in a position to tell you that. So I think the best advice over here will be to make up your mind and concentrate on one thing. If you're planning to come to Australia, then maybe focus on AMC part 1, give the exam, clear the exam, continue your job approach over there, apply for jobs here from there as well, so that you have your recency of practice and everything, and then progress forward from there. But if you want to do specialization, see, because coming over here will be like giving AMC part 1, part 2, and then securing a specialist pathway. If you're getting in India, if you want to have you have some thing in mind that I want to do specialization in something, then maybe AMC is not for you. So it depends on whether what your long term goals are. So if it is definitely coming to Australia, then just focus on AMC.
okay. Thank you.
All good. Yes, I think Dr. Dharmesh want to ask something.
Yeah, I was asking, is there any like a syllabus or anything regarding the AMC part one, the topics that need to be covered?
Yes, Dr. Dharmesh. There is no official publication of any syllabus or something, but we do have a list of important topics. It is basically, I think, those topics which are actually repeatedly asked, or actually are more, in terms of clinical situation. Also, these topics are very important. So, what we will be doing is, when we are delivering our, say we are starting. Supposedly, we are saying we are starting with gastrointestinal system. So and in the beginning of the system, we will provide you a list of all the important topics which we have to cover, because sometimes it is also not possible for us to cover everything in 2 hours or in 4 hours. Sometimes the topics are something, they are very vague kind of a topic. They might be covered in recalls only. You cannot cover them as a theoretical topic. So we will be providing you a list that these are the important topics which you have to go, thorough. You have to be
Okay.
thorough with those topics. So we with
And
every
yeah.
yeah.
And from the basic science, they have this significant coverage or just a minimal clinical basic kind of
So, see, it is
biochemistries and all.
those, if you ask me about questions in AMC with pre or paraclinical subject, they are mostly an app, integrated questions where you have to apply your knowledge in terms of those things. They are hardly any direct questions. Direct questions which comes are mostly with imagining, X-ray, CT scan kind of a thing. But we do need to have a knowledge of biochemistry, pathology, and even anatomy. And until and unless you don't know what to see, what will you see in X-ray? If you don't know what is small and large ball difference, how will you appreciate it? So basics are needed, and I would say it is actually needed because every question, though it appears same, it is not same. Reasoning changes with every question. So there comes the
Okay.
role of your basic.
Yeah. And previously, the other fellow, I think Dr. Rohit, he was I think what he meant to us was currently he's MBBS, and after getting AMC and working there, and after he does some specialized training, and if he decides to come back to India, will that be valid in India, and can he work as a specialist in India with that degree or not? Like for UK, like if you get MRCP. And after coming India, MRCP is recognized, but the specialist training that he will get in Australia, will that be valid in India later on or not?
Um,
I,
so I think depends on what specialization he's doing. I think RSCGP and RNC, like the Obskynic or Royal College, it's in UK or Australia, it is the same. If you're doing anything, the fellowship
okay.
trainings which you're getting is from Royal College only. So I think it should be recognized. I'm not too sure because that way I have never approached the things, but maybe I'll gather some information and convey to you. But mostly it should be recognized. Like it is the same thing. Royal College is providing the thing, so it should be
Okay,
recognized.
thank you so much.
So we have some question in the chat box. Dr. Ankush want to ask, will preparation for USMLE step 2 help in AMC? Um, I think I would like to address this question by the same thing. In terms of your medical knowledge, it is the same. Appendicitis is same in USMLE, appendicitis is same in AMC. What differs is you have to, acquaint yourself with the questions which are coming in AMC. And AMC also, you have to keep an eye on recalls coming in AMC because most of the time these are the very important part of the exam. So I am not sure whether completely preparing for the exam will help it or not, but yeah, the exam pattern I think is different. So depends how you're preparing for the exam. Anyone else would like to ask anything? Yes, doctor. So do I need to do AMC 1 and 2 to get Australia, or I'm okay with AMC 1 which can get me a job in visa to work? Yes, doctor. So the question which you're asking about getting a job in Australia after AMC 1, so there are fair chances of getting a job even after AMC Part 1. It also depends upon what is your background. Um, so people have secured jobs in both regional and rural, regional and urban areas even after AMC Part 1. But if not after Part 1, definitely after Part 2, you can definitely secure a job. It does take some time, but it is possible. And yeah, work visa is if you do not have any permanent residency over here, the hospital is happy to offer you, sponsorship visa. So they offer you visa which can help you to work over here. But the question will depends on individual case. For securing a job, what is your background, what is your previous experience in your country, which field you were working, everything counts. um, so yeah, that is how it works. So even after AMC Part 1, you are most likely to secure a job. I hope that helps. And next question by Dr. Yashdeep, regular classes timing and duration. Um, so we will be having classes mostly on Tuesday, Thursday, Saturday, and Sunday. And the timings will be conveyed to you, but in terms, it will be like in Sydney, that will be 8 to 10 p.m. I think for India, that will be 3:30 to 4 p.m., something like that. So once we start the course, we'll convey you the exact timing and details of the lectures. But it will be 4-day per week classes, mostly 2 hours or 1.5 to 2 hours per day. And usually will be in India, it will be in afternoon or evening time. Any more question, guys? Anything anyone would like to address or question? Right.
Dr. Benny has asked a question.
I actually okay. Can a fresh graduate get a job offer after part 1? Dr. Benny, it is there are no fixed criterias, or there are no fixed official announcement which are done in terms. So it is like try and see thing, but people have secured job even after just completing internship. So there is a fair chance of securing a job. It actually securing a job is not it depends on just one thing, clearing an exam. It also depends upon what you're presenting to them. How is your resume? What is their requirement? Are they in dire need of a person? So they might take you. So there are many factors in terms of securing a job, but yes, there is a possibility that even fresh graduate can secure a job offer. It is just that securing an internship in Australia is little difficult, but if you have completed your internship in your home country, then after part 1 you can definitely secure a job offer over here.
I guess we don't have any questions left. If anybody has any question, please feel free to ask in next 1 or 2 minutes. Yeah, I think there is a question on the chat box.
So regarding the question with Ankush, I think Dr. Udara will be in a better position to answer this. So if she is there, I would like to, yeah. Hi, Udara. Can you please address that question regarding the online internship from China?
Yeah. Actually, like this is an online internship from China, or is it an internship that you have done pre-graduation in China? And Ankush, is it an online internship or an internship that has done like before graduation based in China?
It's a pre-graduation internship.
Like you have been in the hospital, or was it online?
No. I have been in India and I've been doing like internship online.
Okay. So actually, like what I have known till now is like an online internship. I am not sure about Australia, but it's not recognized according to my knowledge that I have searched for. But the pre-graduation internship here, they will recognize it only. Because like I think pre-graduation internship, they will not consider it as an correct internship because from the part one, what we'll get is limited registration. For that, according to Australia, they will need an internship after graduation. But if you do and if you completed it, you will be eligible for provisional registration. For that, that internship will be valid, and there are people who got the registration with part two and pre-graduation internship. But you can try to secure an internship here according to your year of graduation. If you have graduated within 2 years of time with part one, even you can try for an internship, but it's not like a completely easy task to do. But there are people who got internship with part one only. But then the procedure will be different. So internship, you will also get limited registration, but you have to work after 2 years as an RMO under supervision. But if you directly go for provisional registration part two, you can work like only for 1 year with supervision and then directly go for your general registration.
Oh, okay, so I
But
can
I
get
think-
provisional registration, right?
Yeah, because with part two, you can go for provisional registration and work for 1 year and then you will directly get the general registration. Because with part two, like if you have done under supervised limited, like if you have done part one only, you only get limited registration. It's like that. And then with the limited registration, you have to work for at least 1 year under supervision to be eligible for general registration, but you have to complete part two as well, or WBA. But in this case, with Chinese internship, they say it's better that we do part one and two both, and then get the provisional registration and work 1 year with provisional registration under supervision, and then we can directly go to general registration.
Okay, thank you. How hard is to get the provisional registration? Is the same? Is it same difficulty?
So part two is but actually it's the same procedure. The only difference is that people who have like so much experience, they will get part one and they will get the limited registration with Australia.
Okay.
But with people who have this internship, they will do part two, but they are not working and they have to wait for some time with like doing part two. And they will directly get the provisional registration. So anyway, like even with limited or provisional, like it's the difference is only the timing. Like limited registration, people also have to do part two within 3 years of time.
Okay,
But
okay.
here, like we have to do part one and two both like before.
Okay.
But
Thank you.
you can also like try to find an internship with part one only as well. But there are some possibilities. It's less possibility.
Thank you so much.
Yeah, no worries.
I think there is one more question. I don't know the name, if I'm reading it correctly. PGI Desire NQ.
Yeah, so
Oh,
they
yeah.
are, yeah, they're asking about part two. I think coaching for part two, and how long should be the internship? I only have 1 year post graduation. So yes, 1 year internship is what they are asking. You just need to have an internship completion certificate with you, which is detailing your work done in your internship year. So that is sufficient. For part two, I think our academy is planning to start with part two as well. As we roll on with the part one, in upcoming few months we will have part two started as well. I think we are done with the questions. Any more question, guys? Anything anyone else need to? Okay, I think then we can end this session. And we do have another class coming up on 27th. I think the same timing. You will be shared with the link and everything on the group. So please do join that class as well. Dr. Udara will be taking that class. And we do have a feedback form shared in the chat group. So it will be much appreciated if you guys can fill up that form.
Thanks, Dr. Swapnil. Thanks, Dr. Udara, for your presence.
Yeah.
For the time.
Okay. Thank you guys. Bye-bye.
Thank you.
Bye. Bye. And if you guys have any questions, this chat window will be open for another 5 minutes. You can add your questions over here. On